Well, welcome. I think we'll go ahead and start. And if we have a few more people join, that will be great. We had said we would talk a little bit about endocrine lesions. So we'll begin with a little bit about normal. This is the smallest, or one of the smallest endocrine lesions, the parathyroid. And as you know, the parathyroid usually is in the neck, but sometimes is in the mediastinum. And so sometimes it's a challenge for the surgeons to find the parathyroid gland if there is hyperplasia and they need to take them out, or if there's an adenoma. But I think it's important to recognize that the normal gland is quite small, less than a few hundredths of a gram, and it contains quite a bit of fat. And we have a number of different cell types, which can include the normal. And some these can exist in varying proportions. Clear cells are dominant. Sometimes the oxyphilic cells are dominant. In terms of the parathyroid, a nice view of the normal appearance of a parathyroid. Now, as I mentioned, this gland can occasionally be outside the neck, because surgically identifying it can be a challenge. One of the places where surgeons can be is in the thymic tissue with these little small squamous nested areas that sound a little bit like muscles, like this squamous infrastructure. And neoplasms. Now this is very cellular. Yes. It looks more likely to be an adenoma. The oxyphilic cells, which is the two following that. In some ways, and that, to my knowledge, is not specific for pathologic work. Is that develop a parathyroid system?
Sorry, Dr. Hassan, we cannot hear you well.
Okay. Let me check my speakers. So as I mentioned, one of the things that we are concerned about sometimes is a cystic lesion in the neck. And many of you do needle aspiration biopsies. And sometimes this can present as a thyroid or near the thyroid cystic lesion in the neck. And you'll get a fairly clear fluid from these cysts, and very few cells. Many thyroid cysts, of course, will have sort of a degenerative appearance. These usually will have very little in the way of epithelium. You can see there is a little bit of epithelial lining to these cells or to this cyst. And so you might get a few of these, follicular type cells. But on a needle aspiration, you might have difficult time distinguishing between a thyroid follicular epithelium versus a parathyroid follicular type epithelium. They can look very similar. The one thing that could be diagnostic, however, is doing a chemistry on this fluid. And if you tested the fluid for calcitonin or a PTH or other parathyroid-related chemistry, you would usually identify a higher than expected level of that as compared to, other proteins or other cystic lesions. So just a consideration for thyroid cysts, parathyroid cystic lesions that can occur. So the usual and most frequent cause for surgery of the parathyroids is an adenoma. But there are patients who have renal failure or in some familial settings where they can have hyperplasia. And so you may identify a dominant gland and have, abundant parathyroid tissue. You can see this is very cellular, very little fat remaining in this gland, just a little bit here. But with just one gland, it can be virtually impossible to distinguish an adenoma from hyperplasia. And so when you get a frozen section on something like this, you just say, hypercellular parathyroid tissue. And then it's the surgeon's obligation to identify the other glands and verify either that the other glands are not enlarged, and therefore it's an adenoma, or to remove other glands and verify that they are not, that they are hypercellular and therefore potentially a part of hyperplasia. In that setting, they usually would remove 3 or 3.5 glands, leaving some parathyroid tissue behind to try to control that hyperparathyroidism. So surgically or histologically, it's really quite difficult to tell an adenoma from hyperplasia on the basis of a single sample. Here, for example, is an adenoma, but some of the things that we look for in an adenoma, such as a peripheral rim of normal parathyroid tissue, we don't have. We have some thyroid tissue, but we don't have any peripheral normal parathyroid tissue. As you see, we can get a degree of mild nuclear pleomorphism and different cell types. Here's more of the clear cell types or water clear cells that we see. And there are adenomas that are almost pure water clear cells. In fact, Dr. Zwan sent me one not too long ago that was predominantly water clear cells. And here you see there can be areas of hemorrhage and even some fibrosis. Now, sometimes when we start to see fibrosis like this, we worry about carcinoma, because fibrous bands are one thing that can be seen in parathyroid carcinoma. But that is not a sufficient criteria to make the diagnosis of carcinoma. We'll talk about that here with a couple of other cases. So here is another hypercellular parathyroid gland. And as you can see, this has a bit of a capsule here. But notice what we're beginning to see. Here's an area where we have capsular penetration. Now, unlike the thyroid, where this would be sufficient to make the diagnosis of minimally invasive follicular carcinoma, that criterion has not been firmly established in the parathyroid. But if you see this, you should look very carefully to make sure that you don't have other criteria that would establish malignancy. And especially in this situation, we see another area of capsular penetration here, and probably another area here where it's gone beyond and begun to grow. So this lesion also was an adenoma because we did not demonstrate those other features, which we'll talk about in just a second. But notice here that, again, you can have some degree of nuclear pleomorphism and atypia, macronucleoli, these variable size nuclei. These do not equate to anaplasia or malignancy. Now, if you do see a rim of normal gland, and there was an area here that looked almost like that. Let's see, where are we here? Oh, yes, up here. This area here looked a little bit like it might be normal parathyroid tissue. It's certainly less cellular, but notice again that we don't have any fat here. There's no residual fat in the parenchyma here. So I'd be a little reluctant to say this is unequivocally normal parathyroid in the absence of any parenchymal fat. That said, that in some situations you might use a fat stain like an oil red O or a methenamine blue, or methylene blue on a frozen sample to see if within the cells itself you had abundant or a difference in the amount of lipid, because normal parathyroid has increased parenchymal fat, but it also has increased intracellular fat. And so if all of this clear material is lipid, that may be an indication that at least this portion is more normal and will probably be different than this area in terms of the amount of cellular lipid. So I think I've got one more example here. And this is where we'll talk about parathyroid carcinoma. So there are 5 criteria that can be very helpful in establishment of malignancy. And the most important one is the one that we see right here, which is nicely marked, where we have not just capsular penetration, but we have invasion of this parathyroid tissue into a vascular space. And we can tell this is a vascular space. We've got red cells here. We've got a nice endothelium. And here is this bud of tumor extending into that lumen. So that's pretty convincing. Now, we also have other areas over here where it looks like we have capsular penetration, like we saw on the earlier sample, where here's a big gap in the capsule and tumor extends through that. And as well, we have what looks like it might be a vessel here. Certainly this is a vessel. So if you get a situation like this, and you don't see definite vascular invasion, but you're concerned about that, it would be good to possibly do levels, or to make sure that you had totally embedded the tumor so that you can look for any other evidence of malignancy. Now here again is probably another area where you've got a little bit of capsular penetration. You just don't see the gap right here. And again, this is something where levels might show you more of this. Now, in this particular gland, we do have some little islands of parathyroid tissue that are compressed and entrapped within the capsule. And so this is one feature in parathyroid carcinoma, is that it tends to make a thick capsule that compresses the adjacent parathyroid tissue. And just like we can use that in the thyroid, this thicker fibrous band or capsule can be a suggestion of malignancy. So in addition to the criterion of vascular invasion, another very firm criterion is invasion of adjacent tissues, adjacent organs. So invasion into the thyroid, or invasion into skeletal muscle, or clear-cut invasion even into fatty tissue could be grounds for identifying it as malignant. One clinical marker that you might find helpful in determining if this is the case is if the surgeon had a difficult time removing the gland. That is oftentimes an indication that you have dense fibrosis and that you have invasion of an adjacent tissue. And then the last criteria that is, of course, definitive is metastasis of the tumor to another site. So if you've identified it in a lymph node or in a bone or other location, that would certainly be grounds to identify that as a malignant parathyroid carcinoma. Mitotic figures, necrosis, those are uncommon features. If you find them, and they're certainly clearly increased, you might again lean towards the possibility of malignancy and investigate more firmly for these definite areas of meeting the malignant criteria. Now, another feature, again, that can be suggestive of parathyroid carcinoma is if you have a PTH level that is 3 times the upper limit of normal. So it's a really markedly elevated. That is, again, a soft marker, as is the presence of hypercalcemia that is above and beyond 14 milligrams per deciliter. So highly elevated calcium, highly elevated PTH levels can again also be suggestive of the possibility of malignancy. Here's an example of a tumor that was very closely adherent here and on additional sections was actually invasive into the thyroid. Again, this is a case where we had some possibly peripheral parathyroid tissue that had shown some evidence of old hemorrhage. But notice again that this does not have any residual parenchymal fat. And we had this area here where we have penetration, and here an area of likely vascular invasion by this neoplasm. So several of the criteria are met there. Again, we do have some cellular pleomorphism, but as we've seen, that's not a highly reliable predictor. Okay, well, this is something that we see more often is the thyroid. And I believe we were. So this is just to remind us of what the normal thyroid looks like. We have nice, round, lightly uniform nuclei, low cuboidal cells, solid colloid, and not much in the interstitium. So keep that image kind of in your minds, recognizing, of course, that there's a variety and a range of things. I'm going to actually skip this case. One of the lesions that causes us a lot of challenge is the new classification of the follicular lesions that have nuclear features of papillary carcinoma. So here we see a few small nucleoli, enlargement, some overlapping of the nuclei, but we have a totally follicular structure, a little bit of solid growth here, but again, just mild nuclear atypia of the sort that we would see with and associate with papillary carcinoma. And we see this in a setting where we're pretty well encapsulated here. You see this nice solid demarcation here. So previously, we might have called a lesion like this the follicular variant of papillary carcinoma. But as you know, the evidence has accrued and we've changed the name of that lesion so that if we have pure follicular growth in a lesion with nuclear atypia resembling papillary carcinoma that is entirely encapsulated, this is no longer considered a malignancy. And of course, that has that new name of the non-invasive follicular tumor resembling papillary thyroid cancer. So it's a very interesting name. Now, this is, I think, a very instructive slide because, as you can see, there are two lesions here. We have this lesion here, which is nicely encapsulated, even though it's a little bit indented. And then we have this lesion, which has a little bit of capsule, but obviously spreads beyond it. So we'll look at this lesion first. And as you can see, here we have a very nice demonstration of the nuclear atypia that we associate with papillary carcinoma. Some overlap, some nuclear grooves, occasional inclusions, and some micronucleoli, and so forth. Now, some of this has a follicular architecture, as you see, but in a few areas, we actually have a more classical architecture with some papillae. And this, in contrast, appears to have an invasive growth pattern. So here's some of our papillary classical architecture. And here, our tumor up here is extending beyond any sort of capsule into the adjacent thyroid tissue without any strong capsular margin or anything like that. So I think you'll agree with me that this is a nice example of papillary carcinoma. But if we look at this lesion over here, here we do see this capsule, and we see, again, solid to totally follicular pattern growth. But lo and behold, when we look at higher magnification here, again, we're seeing this clearing of the nuclei. We're seeing a little bit of nucleoli, some overlapping of the nuclei. There are some grooves in a few of these cells. If you were to look very closely under your microscope, you see a little bit of the scalloping of the colloid. So this has the nuclear features of papillary carcinoma, and particularly as we get into some of the more solid areas here, you can see these nice grooves and the nuclear enlargement. And so this, I think, is a classical papillary thyroid carcinoma, as well as our new encapsulated follicular lesion with nuclear features resembling papillary thyroid carcinoma, or the NIFT-P. So a nice comparison back to back of how those lesions are similar and how they may differ somewhat. Now, this is fragmented a little bit, but I think you can take my word for it that it was totally encapsulated. Again, we don't just make that diagnosis on the basis of a single section. We would want to fully examine the margins to make sure that we did not have invasion from this lesion. because if this were invasive papillary thyroid carcinoma with a follicular pattern, it would change the size and the staging potentially for this lesion. So I think enough said about that lesion. Let's stay in the thyroid and talk about the other component lesion that we can identify in the thyroid. And that is related to the parafolliculars or C cells that we can identify in the thyroid. So here we have what looks like fairly normal thyroid tissue. We have a few lymphoid clusters here. And I think, I'm trying to remember, I did mark some of these. Let's see if no, I didn't. So this is from a patient who had a family history of multiple endocrine neoplasia. And as we look around here, I think we'll be able to identify some areas of possible C-cell hyperplasia. And I wanted to show that to you. It's not striking or overwhelming, but there are several areas where I think you'll believe me. Let's see if we can find it here. Obviously, this is a diagnosis that you're not going to usually make de novo, but in the setting where you have, well, here's a little bit of hyperplasia in the parafollicular cells, and some of this may also be that. The areas that I saw earlier had nice clear cytoplasm. And of course, you could do a stain for calcitonin or even a CEA stain, which is kind of as we used to say, a poor man's calcitonin, to identify these parafollicular cells and convince yourself that they were hyperplastic or more frequent than normally would be seen. I think here's some more of these parafollicular cells here. Oh, here's a few more here. So here's some of the ones I was seeing earlier where you get a little bit more clearing of the cytoplasm. They tend to plump up a little bit more. Here you see some more in here, some more in here and here. And this underscores the fact that when you identify a patient with a medullary carcinoma, it really does behoove us to identify and screen the family as well, either using biochemical methods, and if they have an elevated level, potentially taking them to surgery, because medullary carcinoma is very difficult to control once it has begun to take control and spread, become a clinically evident neoplasm. That's both in terms of the biochemical effects as well as in terms of its degree of growth. So here are more of these areas of parafollicular C-cell hyperplasia, and you can see that some of them even invade into the follicles here a little bit, maybe even here. So that's a lesion that we don't see very often, and yet you want to be prepared for it should it happen in your setting. Here's the more frequent situation is identifying the neoplasm. And medullary carcinoma in the thyroid is one of these lesions that can be quite variable. Now here's a lesion where we have a fairly cellular tumor, mostly solid growth, fairly pleomorphic and mitotically active cells, slightly grayish cytoplasm, it looks a little bit like a paraganglioma or even like a pheochromocytoma type of lesion just because of this growth pattern. But it can have a pattern that looks very follicular. It can look like a follicular carcinoma. Because of the nuclear atypia, it can look a little bit like papillary thyroid carcinoma or anaplastic carcinoma. It can look a little bit like plasmacytoma if it's very well differentiated. The nuclei can be a little bit eccentric and so forth. So you have to have a very low threshold to consider medullary carcinoma because of that variability. Now, we know we often associate amyloid with medullary carcinoma, and I think you've got a little bit of that type of pattern here, as you can see, but it's not very diffuse in this lesion. And if you didn't happen to sample this area, you might miss it because you might just have a few scattered foci of the amyloid type of deposition, and not all tumors are going to have it. Now, in contrast, this next case has lots of amyloid. In fact, it's so sclerotic here that you might almost wonder if this is a lymph node that's become sclerotic or some other lesion because it doesn't really look like thyroid parenchyma, except out here at the periphery. So the amyloid can be quite variable, present, absent, abundant, minimal, and the morphology of the cells can be quite variable. Now, this is not a great section, but I think you can see there's much less pleomorphism here. There's a little bit of sort of follicular pattern growth that may be entrapped residual thyroid tissue, and it can be sort of solid, obviously quite variable based on the duration, based on the setting, and so forth. So here's more of a follicular pattern to this. Again, very hard to distinguish whether or not that's entrapped thyroid or medullary carcinoma with a follicular pattern. So, of course, classic, well-differentiated thyroid tumors are, of course, more common. And I just include this for sort of completeness sake to illustrate true capsular penetration in a minimally invasive follicular carcinoma. Here we can see there's a follicular pattern. As we look at the nuclei here, we don't see the same degree of atypia. We don't see clearing, grooves, or the other features that we saw with papillary carcinoma. And we do see the nice pattern of capsular penetration here with this sort of mushroom cap type of extension beyond the capsule. Now, sometimes you might this is how we get close to vascular invasion, when we get tumor that's growing like this. Just a little further and it would be truly subendothelial. You might be inclined to call that vascular invasion if you just have a minimal amount of endothelium overlying the tumor. But certainly we don't need that in follicular carcinoma to make the diagnosis. Again, you'll notice that this follicular tumor has a fairly dense capsule, and we see other areas where we get suggestion of invasion or indentation of this capsule. These tumors are notable for making new capsules after they've penetrated, and so that's something to be aware of, that if you get penetration like we have over here and it sticks around for a little while, this is going to provoke additional fibrosis around this area. And so it may look like this is still encapsulated in a single focus. Okay, I'm going to pause here. I think did I pick up the, okay, I think we're okay. All right, let's move on to a more clearly invasive lesion, and one that usually is not a terrible diagnostic problem. This is another variant of follicular carcinoma, the so-called Hürthle cell variant. You can see these very oxyphilic cells here, and these can look very bland, as you see here. Lots of cytoplasm, generally fairly uniform nuclei, and so forth. So if you just have a fine needle aspiration of this lesion with lots of oxyphilic cells, you might just say, oxyphilic neoplasm. But as you can see here, this is a tumor that is extending into fat. Here we see it is invading the parathyroid gland. Here's a normal parathyroid gland, and we have two little nests of neoplastic cells here, maybe within vessels, hard to tell. Here it looks like we have tumor inside a vessel there. And then we also have the tumor invading, and causing a very dense sclerotic reaction with a clearly invasive pattern into the adjacent soft tissues. So no problem in defining this as malignant, but unless you're just dealing with the cytology, in which case this might be very difficult to classify as malignant based just on the cytology. And that's one of the reasons why, when we see a Hürthle cell neoplasm, we generally recommend that they consider excision, is because this pattern is a little bit more common with Hürthle cells than with just cellular follicular adenomas. Now, another tumor that can look deceptive is the so-called poorly differentiated carcinoma, or previously called insular carcinoma. Again, this can have quite a variety of morphologies, with some areas being more typical papillary carcinoma and other areas showing this more solid, almost sort of carcinoid type of growth. You can see here, if I just gave you this one field, you might say this looks like a cellular follicular adenoma. We have a couple of follicles here, we round nuclei, and so forth. So it could be on needle aspiration, could be concerning for just a cellular follicular adenoma. But as you see, we've got a pattern of invasive and permeative growth here. And in some areas, at least, we should begin to see these nice nuclear grooves, a few nucleoli, and we might find some more papillary carcinoma type of nuclear features here in this lesion. These tumors, I believe, ontologically probably represent a stage in the dedifferentiation of papillary thyroid carcinoma. They tend to mimic those in terms of some of the molecular alterations in terms of BRAF and so forth. But they also tend to begin to accumulate other mutational changes, like mutations in TP53 and so forth. So this lesion of poorly differentiated carcinoma is not a good stage. It's not as bad as anaplastic carcinoma, but it's clearly not a neoplasm to be trifled with. And it can look relatively bland on cytology, as we've indicated. Just take one more look at these nuclei. And I think you can see this might be, thought of as a, neuroendocrine tumor or something like that. If you didn't know where it had come from, I could persuade you that this was maybe from the pancreas or from a GI site. with this sort of insular pattern of growth, a few sort of pseudoglandular foci and so forth. Well, this is kind of a little treat, and I included this case because I haven't seen very many of these cases, and I wanted to share and learn about it with you. I think in some respects it could be confused with some of the lesions that we have looked at, because as we look at this lesion, you'll see we have a nice cell ball appearance of these cells. And there's also this very sclerotic area in between. So we might think about medullary carcinoma, or we might think about paraganglioma. We might think about a sclerosing variant of papillary thyroid carcinoma. Because these nuclei are a little bit atypical. There's maybe a groove or two. But there are a couple of features that may, if we look closely, they may help us. So notice here, there's a little bit of a yellowish tinge here to some of the cytoplasm. Here we have a nuclear inclusion. But if we look around a little further, I think you'll see a few more of these pale yellowish, slightly golden bodies. These are so-called yellow bodies that are characteristic of the hyalinizing trabecular tumor, which, as you can see, is in this differential for the lesions that I've mentioned: papillary thyroid tumor, medullary carcinoma, paraganglioma, and so forth. It has a lot of this very abundant hyalinized stroma. It tends to form these small balls or nests of cells, and this would be negative for amyloid should you do the Congo red stain. And notice that some of the cells have this nice tall cell type of appearance. So you might even be thinking about the tall cell variant of papillary thyroid carcinoma. I'm sure when I was first in training that people would have called this a variation of the sclerosing papillary carcinoma type of tumor. But over time, we've learned that this has a slightly different prognosis and a different molecular signature. It does not have the usual papillary thyroid carcinoma changes. It tends to have a different molecular alteration, which I think is GLIS mutation, if I'm correct. And then, of course, it has these occasional yellow bodies that can be somewhat subtle, but are definitely present in this tumor. All right. Well, as I indicated, one of the things that's in the differential for these tumors is paraganglioma. So I thought we'd take a minute or two and talk about paragangliomas as an endocrine tumor, and just review the morphology and locations where we can see these. Of course, most frequent location is in the adrenal or as a pheochromocytoma. But we also can see them in the mediastinum and in the neck, occasionally even in the middle ear, as well as along the sympathetic chain in the thorax and abdomen. Again, these are lesions that tend to have sort of a grayish cytoplasm. You can see grayish purple cytoplasm. There is some variability of the nuclei, not necessarily predictive of metastatic potential. And this sort of balling up of the cells with characteristically a sustentacular cell surrounding them that is S100 positive. So here's one example, and you can see the variability and the very vascular nature of this lesion. They can look sort of angioinvasive because they're very vascularized and are associated with, the circulation and so forth around these chemoreceptors in the mediastinum, the neck, and elsewhere. Here's another example. Here, this one has a very anastomosing vascular network and some hyaline type collagen here. Again, we see a nested pattern, a little bit more clear cytoplasm than the grayish purple we had in the last one. Less nuclear variability, but there's still some. And very, very vascular. So I think you can see how, sometimes this might resemble the hyalinizing trabecular tumor or medullary carcinomas or other things that we've just touched on already. And then another example, I think this one is from the adrenal. And in this case, because of the vascularity, radiologists have tried to embolize the tumor. And so you get a little bit of this embolization material in the vessels and associated hemosiderin deposition from hemorrhage. Again, we see a lot of this hyalinized collagen, small nests and balls of cells with characteristic sustentacular cells. So this is the German word is Zellballen for cell balls, and obviously they can have a very hyalinized and fibrotic appearance, areas of hemorrhage, maybe unrelated to embolization. And you can see the example here. So we've got a few more minutes. I thought I'd just put one up here for, this is not really an endocrine lesion, this is an adrenal. And usually this is a lesion that the radiologists can identify on CT scan and it won't get resected. So this is sort of an old case of an adrenal. And you can see here the cortical nests of cells, typical endocrine cortical cells. And within the adrenal, we had this lesion, which has fat in it, and a variety of cell types, which look very much like bone marrow. Here's some megakaryocytes, here's some red cell precursors, here's some granulocytic precursors. So we see that we've got a sort of a marrow-like appearance, and it's occurring as a mass lesion in the adrenal with associated fat. So the term they use is myelolipoma. Again, this is a lesion that you're probably not likely to see come across the surgical bench, maybe at autopsy or something like that, but because it's a benign lesion, radiographically identifiable now. Okay, well, I think rather than do the rest of the slides I've got, we should maybe pause and see if you have some questions about this, and we can talk about the adrenal lesions next time. So I'm going to sort of pause the share at this stage and see if you have any questions you would like to ask. Feel free to unmute yourself and speak, or to write your question in the chat.
Thank you, Professor. And I have never written C-cell hyperplasia in my pathology report, and about the new C-cell hyperplasia, I have never written it in my pathology report. How about you? It's necessary to write.
Well, I can't hear you, Dr. Lin. I think my speaker went off. So let me switch speakers here.
The professor, I have never written C-cell hyperplasia in my pathology report. How about you? Is necessary write this in pathology report?
I have never had a case to make that diagnosis. So I think if you had a patient with the right history, and I think if I saw the morphology and maybe had some immunohistochemistry to support that diagnosis, then I would feel confident in making the diagnosis. But I think multiple endocrine neoplasia maybe is not very common in Asia. Is that true? What do you think?
Yes. In my country, in my hospital, I have often diagnosed endocrine lesion in parathyroid and in unreal gland.
Yeah.
And in thyroid, thyroid tumor is very difficult to distinguish some follicular adenoma and medullary carcinoma. I have seen medullary carcinoma negative with calcitonin and CEA. How about the marker neck stem with tumor medullary carcinoma?
Yeah, so that's a good question. If you don't have supporting immunohistochemistry, I certainly think if you had a setting of a patient who had other neuroendocrine lesions and was likely to have that, or if they had an elevated serum calcitonin prior to surgery, then I would make that diagnosis without the immunohistochemical support, because sometimes immunohistochemistries that we don't use very often can be difficult to control or to get right. So it's certainly positive that or likely that a false negative immunohistochemistry result could be found. But I think that's where it's nice to pull the clinical, the genetic, and the morphologic findings together.
Thank you. Because in my hospital, there a tumor in thyroid, the surgeon doctor surgeon often cut it without serum calcitonin test before the surgery.
That's
No.
probably also true. But sometimes they may have done some other lab tests, like hemogram or chemistries. And so sometimes you may still have a blood sample in the laboratory in storage that was drawn preoperatively. And you can, if you are quick, can sometimes retrieve that sample to test for calcitonin in the serum. So we have done that a few times where they weren't thinking of possible, medullary tumor, and we were able to identify that value in the preoperative blood sample. Now, that brings up an interesting point relative to parathyroid tissue or parathyroid surgery. A very important finding is that in patients who have an elevated PTH and have hyperparathyroidism, if they have an adenoma and the adenoma is removed, the PTH level immediately after that will begin to drop very quickly. And that is almost as valuable as a frozen section in helping the surgeon to know that they have removed the disease. In contrast, patients who have multi-gland disease, hyperplasia, after they remove that first gland, the parathyroid PTH level will only decline gradually or slightly. And so how much the decline is can be very helpful to the surgeon to know if he needs to look for more abnormal glands. Because it's a challenging surgery to find these very tiny parathyroid glands in the neck, and you don't like to have to operate longer than you need to. So in areas where they're going to do very much parathyroid surgery, it's very useful to have the capability to do a stat PTH level intraoperatively so that they can get that value while the patient is still being operated on. Good questions, good discussion. Any other questions? Well, thank you so much for joining me tonight or this morning. Because of the Christmas holiday in the US, I'm going to suggest we do the first Friday after the new year. So that would be January 5th, I think,
Yes.
for our next meeting. And if you have, if some of you would like to present a case for discussion, that would be a very good opportunity for us to share that. You don't have to have a digital slide. You can present fixed images, and we could talk about the cases together. I'd love to see Dr. Ha or Dr. Mary, one of you, to share a case that you're pleased with, you learned from, or you have questions about. And that way we can all learn together.
Thank you, Professor.
Okay, have a great day, and we will see you after Christmas.
Thank you. Goodbye, Professor.
Bye.
Goodbye.